Yo, welcome back to the channel, everyone. This is Mike with Strudel Medicine Reviews, and today we'll be doing part one of our infectious disease review. So make sure to like and subscribe if you haven't already, and let's get right into it. So, question numero uno. A 40 years old gentleman with untreated HIV presents with 2 weeks of headache, low-grade fever, and photophobia. He is mildly confused and exam reveals neck stiffness. MRI is normal. Lumbar puncture shows an elevated opening pressure, low glucose, and lymphocytic pleocytosis, whatever that means. India ink stain reveals encapsulated yeasts. So our question is, what is the most appropriate initial treatment? Is it A, oral fluconazole, B, IV amphotericin B and flucytosine, C, IV vancomycin and ceftriaxone, D, IV acyclovir, or E, oral TNP SMX or Bactrim? So what are we thinking here? So you should be saying that the answer is in fact B, IV B and flucytosine. So what leads you to answer choice B is that first you need to identify that this patient, who's a 40 years old gentleman with untreated HIV, presenting with neurologic symptoms and then encapsulated yeast by India ink stain, has cryptococcal meningoencephalitis. So treatment of cryptococcal meningoencephalitis requires IV amphotericin B and flucytosine initially for the induction therapy. After the initial induction therapy, then you can transition to fluconazole for up to 6 months for the maintenance phase of treatment. But initially for the induction therapy, you need IV amphotericin and flucytosine. The other answer choices are incorrect. IV vancomycin and ceftriaxone is used for acute bacterial meningitis, not fungal meningitis, as is the case here. D, IV acyclovir is used for viral causes like HSV, but not cryptococcal infections. And then E, Bactrim is used for PJP pneumonia, which is a HIV kind of defining illness, but not cryptococcal meningitis. All right, onwards. All right, question two. So let's say we have a 28-year-old man presenting with fevers and headache after returning from Nigeria 2 weeks ago. Exam shows scleral icterus and splenomegaly. Labs reveal anemia, thrombocytopenia, and elevated LDH. Peripheral smear shows ring-shaped trophozoites in erythrocytes. What is your next appropriate step in management? Is it A, start doxycycline and atovaquone, B, start IV quinine and doxycycline, C, administer IV artesunate, D, initiate chloroquine therapy, or E, order a liver biopsy? So here you should be thinking about C, which is administer IV artesunate. So the way you'd come to this answer is first you need to identify that this gentleman is presenting with fevers and headaches in the setting of returning from Nigeria, and also has scleral icterus and splenomegaly with thrombocytopenia. And then the really giveaway is on the peripheral smear, you see ring-shaped trophozoites and the erythrocytes. So this is an example of malaria, which is caused by the Plasmodium falciparum parasite. So first line therapy will be your IV artesunate or IV quinidine where unavailable. The other answer choices, so you want to think about, in Plasmodium vivax infections, you can use chloroquine, but in areas with chloroquine resistance, and you still want to administer like your ACTs, which is your artemisinin-based combination therapies, which will be your most effective therapies against malaria. So the other answer choices that are incorrect, so A, doxycycline and atovaquone is used for non-severe cases or for chemoprophylaxis. B, IV quinine or doxycycline is an acceptable alternative, but not first line. D, chloroquine there's a lot of resistance that's widespread and it's not quite as effective as your ACTs. And then E, liver biopsy is unnecessary because your diagnosis is already established with your smear where you see the trophozoites. All right, question three. So question 3, a 60-year-old man with HIV, CD4 count of 40, presents with adenophagia and dysphagia. Oral exam shows white plaques. Fluconazole is started without treatment. What will be the best next step in evaluation? A, KOH scraping. B, HSV testing. C, change HIV regimen. D, colonoscopy. Or E, EGD. The correct answer here is actually E, EGD, and that's because this patient likely has CMV esophagitis. So symptoms aren't improving with your empiric treatment with fluconazole, which would be treating like candida. So you want to be obtaining an EGD to rule out viral esophagitis, which can be CMV or HSV, because those will require different treatment. So, all right, question number 4. Woman reports dysuria and urinary frequency. She uses spermicide and is sexually active. Urinalysis reveals pyuria and bacteriuria. Urinalysis is negative for nitrites. Which of the following organisms is the most likely cause? A, Proteus mirabilis. B, Klebsiella pneumoniae. C, Staphylococcus saprophyticus. D, Enterococcus fecalis. Or E, Pseudomonas aeruginosa. So for question number 4, you should be thinking that the correct answer is C, Staphylococcus saprophyticus, and that's because in this question they give you a young woman who has a history of being sexually active and also using spermicide, and then the urinalysis is a negative for nitrite, so it's a nitrite negative pathogen. So that should make you think of Staphylococcus saprophyticus. Because the pH is 5.5, it's not terribly basic, so that would make you think that it's really not Proteus, which is answer choice A. Klebsiella is a gram negative, and I believe is typically positive for nitrites. Same with Enterococcus fecalis. And Pseudomonas aeruginosa is just not a very common cause of UTI in this patient demographic. So, all right. Yep, here we go. Some other high yield facts to know about Proteus is that it causes struvite stones and is more common in complicated UTIs. And again, you're gonna look for that higher pH, which indicates the more basic urine, and that's because Proteus has urease, so it can convert urea, I believe, to ammonia, which is basic, of course. Klebsiella is less common in young, healthy women. Enterococcus is less common in young, healthy women. And Pseudomonas as well is a rare cause of UTI outside of hospital settings or with like an indwelling catheter. Alrighty, question number 5. A 52 years old gentleman presents with acute right leg pain, erythema, and swelling. Crepitus is noted on exam. He is febrile and hypotensive. Labs show elevated white blood cells and creatinine kinase. What is the next best step in management? A, broad spectrum antibiotics and surgical debridement. B, CT imaging of the leg. C, empiric antifungal therapy. D, IV corticosteroids. Or E, observation and serial exam. So the correct answer to this question is A, broad spectrum antibiotics and surgical debridement. And to get to this answer, you need to realize that this patient is presenting with signs of necrotizing fasciitis, including essentially septic shock or at least sepsis with fever and hypotension in the setting of a likely infection of the right leg and gangrene with the crepitus. So that definitely requires empiric antibiotics and surgical debridement. For the other answer choices, B, CT imaging of the leg is incorrect because that would just delay your surgical intervention. Diagnosis of necrotizing fasciitis is a clinical diagnosis. C, empiric antifungals are incorrect. And that's because you're not really suspecting a fungal etiology. Most necrotizing fasciitis is caused by bacteria. It's actually typically polymicrobial. D would worsen the infection with steroids, so you don't want to be administering those. And then E, observation in pseudo exams, incorrect. Anytime a patient is this unstable, observation is the incorrect answer. Same if a patient was presenting with acute unilateral leg pain in the setting of like recent injury to that limb. You want to be thinking of compartment syndrome, and again, you would need to do emergent fasciotomy. So a general rule of thumb for these exams is if somebody is like acutely ill or kind of critically ill, you want to take action. Question 6. Let's say we have a 72-year-old gentleman hospitalized for community-acquired pneumonia that then develops watery diarrhea up to 10 times daily on hospital day 5. He's been on IV ceftriaxone while admitted. He's afebrile and hemodynamically unstable, but stool toxin assay returns positive for Clostridioides difficile. What is the next appropriate management? Or what is the most appropriate management? A, metronidazole orally. B, oral vancomycin. C, IV vancomycin. D, oral rifaximin. Or E, supportive care only. So you should all be getting this one correct. The correct answer is B, oral vancomycin. That'll be your first line treatment for C. diff infection due to its targeted effect in the colon. It's kind of your best first line option on examinations. For the other answer choices, metronidazole orally used to be first line, really more IV metronidazole, but oral vancomycin is more effective and better tolerated. IV vancomycin doesn't reach the colon, so you want to not use that route of administration. D, oral rifaximin is not really used for C. diff. It's more commonly used in like hepatic encephalopathy type picture. And then E, supportive care only, is inappropriate because you need to treat the infection. All right, question 7. So a 33-year-old woman presents with painful genital ulcers and tender inguinal lymphadenopathy. She returned from a Caribbean trip 1 week ago. On exam, there are multiple deep ulcers with ragged borders and a gray exudate. What is the most likely diagnosis? And remember that these are painful genital ulcers. A, chancroid. B, genital herpes. C, lymphogranuloma venereum. D, granuloma inguinale. Or E, primary syphilis. So the correct answer for question 7 is A, chancroid, which is caused by Haemophilus ducreyi, which presents with these painful genital ulcers along with a tender suppurative lymphadenopathy. So the way you can remember that is Haemophilus ducreyi is so painful that it makes you want to cry, which really separates it from the kind of other causes of genital ulceration and lymphadenopathy. So for the other answer choices, choice B, genital herpes, that'll typically present with your rosebud on a rose, or dewdrops on a rose appearance, which is those grouped vesicles and ulcerations on an erythematous base. Lymphadenopathy is usually bilateral and non-suppurative. C, lymphogranuloma venereum, often presents with painless ulcers, followed by painful lymphadenopathy a few weeks later. Granuloma inguinale is caused by Klebsiella granulomatis. Typically, it presents with painless ulcers and no lymphadenopathy. E, primary syphilis, will present, of course, with your chancre, which is painless and clean base, and then you may see painless lymphadenopathy, but again, here you see that painful suppurative lymphadenopathy. All right, question 8. A 30-year-old woman presents with fever and right upper quadrant pain. Ultrasound shows inflammation of the liver capsule with normal liver parenchyma. What is the most likely diagnosis? A, pelvic abscess. B, pyelonephritis. C, perihepatitis or Fitzhugh-Curtis syndrome. D, subhepatic abscess. Or E, ascending cholangitis. All right, so you should be saying hepatitis, which is Fitzhugh-Curtis syndrome. which is a complication of PID, or pelvic inflammatory disease, characterized by inflammation of the liver capsule without parenchymal involvement, which can lead to right upper quadrant pain and persistent fever. Remember that the complication of Fitzhugh-Curtis syndrome can involve formation of peritoneal adhesions, which can contribute to infertility. So treatment of Fitzhugh-Curtis syndrome typically involves IV antibiotics, such as ceftriaxone and doxycycline. Going over the other incorrect answer choices, so choice A, pelvic abscesses would typically present with lower abdominal or pelvic pain and potentially a palpable mass. B, pyelonephritis would present with CVA tenderness and pyuria on urinalysis. D, subhepatic abscess would appear as a localized fluid collection on imaging, not just capsule inflammation. E, ascending cholangitis typically involves the biliary tract, which would cause jaundice and transaminitis, neither of which are present in this case. Question 9. A 45-year-old woman develops fever, hypotension, and confusion 2 days after surgery for a perforated bowel. Her skin is diffusely erythematous with desquamation of the palms. Blood cultures are pending. What is the most likely mechanism of action of her condition? A, delayed type hypersensitivity. B, immune complex deposition. C, superantigen mediated T cell activation. D, autoantibody production. Or E, mast cell degranulation. So here you should be thinking about C, superantigen mediated T cell activation, because this is an example of toxic shock syndrome, or which results from superantigen toxins produced by either Staph aureus or group A strep, leading to widespread nonspecific activation of T cells and massive cytokine release. You can recognize that in this case mostly by the desquamation of the palms, so that cutaneous finding can really clue you into toxic shock syndrome. So going over the other mechanisms or the other incorrect answers, answer choice A, delayed type hypersensitivity is incorrect. Delayed type hypersensitivity is your hypersensitivity 1 through 4, right? So that's typically a mechanism of like contact dermatitis or TB reactions, but not really acute toxic syndromes. B, immune complex deposition is actually a type of delayed type hypersensitivity. It's type 3 hypersensitivity, which is seen in serum sickness or post-infectious glomerulonephritis, but not in toxic shock. D, autoantibody production is, this is just not an autoimmune disease, toxic shock syndrome. E, mast cell degranulation occurs like in allergic reactions, anaphylaxis, which you would expect minutes after an exposure and would present differently than this. It'd present with like wheezing, hypotension due to like vasodilation, things like that. Question 10. A 7-year-old boy presents with sore throat, fever, and difficulty swallowing. He is drooling and leans forward to breathe. He appears toxic and has inspiratory stridor at rest. Vitals are tachycardia to 110, respiratory rate of 45, satting 99% on room air, and temperature of 101.8. What is the most appropriate next step in management? A, direct visualization of the pharynx. B, throat swab culture. C, empiric corticosteroids. D, endotracheal intubation in the operating room. Or E, chest radiograph. So here you should be thinking about D, which is intubation due to suspected epiglottitis with evidence of respiratory compromise given his tachypnea with respiratory rate of 45. So your priority will be airway protection. So anytime you have an unstable patient like this, remember your ABCs, airway, breathing, circulation. So the other answer choices: A, direct visualization of the pharynx. You want to wait to do that until you can secure the airway. B, throat swab culture. Again, you want to make sure the ABCs are stabilized. So you want to you can pursue your diagnostic workup after stabilizing the patient. C, empiric corticosteroids does not address the airway. E, radiograph. That's Probably the second most picked answer if I had to guess. But lateral neck film will show the classic thumb sign of epiglottitis, but should not delay intubation. And remember, classically, you want to think about Haemophilus influenzae causing epiglottitis for board examinations. Question 11. A 29-year-old woman presents with fever, chills, and left flank pain. She reports urinary frequency and dysuria for the last week, but did not seek treatment. Her temperature is 102.4 F or 39.1 degrees centigrade, and she has costovertebral angle tenderness. Urinalysis shows pyuria and bacteria. What is the next best step in treatment? A. Outpatient oral Bactrim or TMP sulfa. B. IV ceftriaxone. C. Oral nitrofurantoin. D. Bladder catheterization. Or E. Renal ultrasound. So here you should be thinking about B. IV ceftriaxone, given that this patient has signs of acute pyelonephritis with systemic involvement, including fever, chills, CVA tenderness. So that would require IV antibiotics and probably hospital admission. Going over the incorrect answer choices, A, TMP sulfa is appropriate for uncomplicated UTIs but not pyelonephritis. C, furantoin, nitrofurantoin, which is also called macrobid. It concentrates in the bladder but is not useful in pyelo. D, bladder catheterization. There's no reason to do that at this point. There's no evidence of retention. E, renal ultrasound. You can do that if you're still having additional concerns or there's lack of improvement, especially if the patient remains febrile after a couple days of antibiotics, because then you'd be worried about an abscess, but it wouldn't be your initial step. You want to treat the infection with antibiotics. Question 12. A 36-year-old gentleman with a history of IV drug use presents with progressive shortness of breath, fever, and fatigue. Cardiac exam reveals a new holosystolic murmur at the left sternal border. Blood cultures grow methicillin sensitive Staph aureus. Which valve is most likely involved? A. Aortic. B. Pulmonic. C. Tricuspid. D. Mitral. E. Bicuspid aortic valve. So here you should be thinking about the tricuspid valve because this is a 36-year-old gentleman with a history of IV drug use now presenting with evidence of endocarditis. So in IV drug users, the most common pathogen is Staph aureus. Again, that's a skin pathogen, and when you break the skin with the IV drug use, then you are more at risk for endocarditis. And the first valve that will be encountered will be the tricuspid valve. Going over the incorrect answer choices. A, aortic valve is incorrect because, again, the tricuspid valve is the most commonly affected valve. B, pulmonic valve is rarely affected, even in IV drug users. D, mitral valve can be seen in left-sided endocarditis, especially with valvular heart disease, but typically that's when you want to think about your subacute endocarditis with your Viridans species. And bicuspid aortic valve can increase the risk of premature aortic stenosis, but less relevant in this case. Question 13. A 7-year-old boy presents with fever, headache, and a rash that began on his wrists and ankles before spreading centrally. He recently returned from a camping trip in North Carolina. What is the best treatment? A. Azithromycin. B. Penicillin. C. Doxycycline. D. Ceftriaxone. E. Chloramphenicol. Probably haven't heard that one in a while. So hopefully you all got this one correct, but the correct answer is C, doxycycline. So almost all tick-borne illnesses are treated with doxycycline. In this case in particular, with the fever, headache, and rash after going to a camping trip in North Carolina, and he probably also presented with thrombocytopenia as well and possibly some petechiae, is an example of Rocky Mountain spotted fever. Doxycycline would be your treatment of choice, but Rocky Mountain spotted fever is actually can be fatal, so you really want to recognize this early. Going over the incorrect answer choices, A is azithromycin. Macrolides aren't really effective against your Rickettsia species. Penicillins, again, aren't as effective. Ceftriaxone, not as effective, but can be used in Lyme disease, which is another tick-borne illness from Borrelia. Chloramphenicol actually can be used to treat Rocky Mountain spotted fever, but it's second-line therapy. Remember, that's kind of can cause the gray baby syndrome. But chloramphenicol is another, I believe it's a 50S subunit inhibitor, but I might be incorrect. It's either 50S or 30S, but it's a protein. It's a ribosome inhibitor. All right, question 14. Question, so a 45-year-old woman presents with a 3-week history of cough, hemoptysis, weight loss, and low-grade fever. She immigrated from India 2 years ago. Chest x-ray shows right upper lobe cavitary lesions. What's the most likely diagnosis? A, histoplasmosis, B, tuberculosis, C, lung cancer, D, aspergillosis, or E, actinomycosis. All right, so here you should recognize, an immigrant patient presenting with weight loss, hemoptysis, cough. That should make you think of TB, and most likely this is reactivated TB, which will present with infection in the upper lobes and also cavitary lesions on imaging, especially chest x-ray. So remember, your primary TB will be, you'll form that Gone complex, but then with reactivation you can form those cavitary lesions. Going over the incorrect answer, A, histoplasmosis can mimic TB, but more common in Ohio and Mississippi River valleys. And again, you don't want to overthink it. I didn't make these questions terribly difficult, so you just want to pick the most likely answer. Lung cancer can cause hemoptysis, but the cavitary lesions are more consistent with TB along with the constitutional symptoms. Aspergillosis can occur in pre-existing cavities of TB. Actually, that's very high yield to know. So if a patient previously had an abscess or TB, they can be more at risk for aspergillosis in the future. Actinomycosis typically affects the sinus tract and doesn't really present with all these constitutional symptoms and fever. And again, Occam's razor, the most likely, or the simplest answer is the most likely, which is TB in this case. Question 15. A 68-year-old woman is hospitalized for sepsis secondary to UTI and treated with antibiotics. 2 days later, she develops confusion and watery diarrhea. Stool toxin assays positive for Clostridioides difficile. What is the mechanism of this condition? A, bacterial overgrowth of Staph aureus. B, cytokine-mediated intestinal inflammation. C, endotoxin or exotoxin-induced apoptosis. D, toxin-induced enterocyte damage. Or E, systemic viremia. So here you should be thinking of D, toxin-induced enterocyte damage. And remember that C. diff produces toxins A and B, which can cause inflammation and necrosis of your enterocytes, which will actually cause the symptoms. So going over the incorrect answers, Staph aureus overgrowth, it's not really associated with the mechanism of C. diff, obviously. Cytokines are not the direct mechanism of damage. Exokine-induced apoptosis is more like your corneum bacterium, your diphtheria, not really C. diff. And systemic viremia is from viral infections. All right, question 16. A 40-year-old man presents with fever and dry cough. He recently returned from Arizona and spent a lot of time hiking in the desert area. Chest x-ray shows a left lower lobe infiltrate. Erythema nodosum is noted on exam. What is the most likely diagnosis? A, histoplasmosis. B, tuberculosis. C, coccidioidomycosis. D, blastomycosis. Or E, aspergillosis. So this one, pretty obvious. 40 years old gentleman coming from the southwest. This is coccidioidomycosis. So again, this is often called valley fever, and can cause that kind of interstitial pneumonia. Other Incorrect answers that you want to be thinking about include A, histoplasmosis, which is typically found in the Ohio and Mississippi river valleys. B, tuberculosis. This, it typically presents with those B symptoms: weight loss, fever, cavitary lesions. D, blastomycosis is found in the Great Lakes and Ohio River Basin. And aspergillosis is seen in your immunocompromised or patients that had previously had cavitary lesions, like patients with TB or an abscess, not really in healthy travelers as much. Question 17. A 24-year-old man presents with a painless genital ulcer that developed 10 days ago. On exam, there is a single indurated ulcer with a clean base and bilateral non-tender inguinal lymphadenopathy. What is the most likely diagnosis? A, chancroid. B, herpes simplex virus. C, primary syphilis. D, granuloma inguinale. Or E, lymphogranuloma venereum. So here you should be thinking about C, primary syphilis, because this is a pretty classic for a chancre. That's the description there, the single indurated ulcer with a clean base and bilateral non-tender inguinal lymphadenopathy. The lesion will actually heal even if it's untreated, but then the patient will be at risk for secondary syphilis. Going over the incorrects, A is chancroid. That's your caused by your Ducryi organism. Remember, that one's so painful that you will cry. That's characterized by painful ulcers with ragged edges and painful lymph nodes that often have suppurative discharge. B, HSV will cause your dewdrops and a rose appearance with your painful vesicles over an erythematous base. D, granuloma inguinale is typically painless, but will also cause beefy red ulcers without lymphadenopathy. And LGV, your lymphogranuloma venereum, starts as a small painless ulcer, but then progresses to painful lymphadenopathy weeks later. Question 18. A 60-year-old man with diabetes presents with fever and severe back pain. Exam shows lumbar spinal tenderness. Labs show elevated ESR. MRI reveals vertebral body enhancement and disc space narrowing. What is the most likely diagnosis? A, vertebral fracture. B, spinal cord infarction. C, epidural abscess. D, osteomyelitis. E, disc herniation. So you should be thinking here osteomyelitis. D, because you have your clinical constellation of focal back pain, fever, elevated ESR, CRP, and your MRI demonstrating vertebral body enhancement, especially, I believe, on T2, and disc enhancement, kind of our classic. Your other incorrect answer choices: A, vertebral fracture. That wouldn't present with fever or elevated inflammatory markers. B, spinal cord infarction will present with acute neurologic deficits, not really infection. C, epidural abscess. This is really the big other one you should consider on your differential diagnosis, but typically you'll have additional neurologic symptoms, or often presents with some, maybe a cauda equina syndrome, or unilateral leg pain, or saddle anesthesia, or urinary changes, none of which are present in this case. Then you'll have also usually pain out of proportion to exam. E, disc herniation. Usually MRI will show disc protrusion rather than your inflammation or enhancement. All right, question 19. A 43-year-old woman presents with right upper quadrant pain, shoulder pain, and fevers. She has a history of cholelithiasis. Labs show elevated alk phos and bilirubin. Ultrasound reveals gallstones and bile duct dilation. What is the next best step? A, HIDA scan. B, abdominal MRI. C, cholecystectomy. D, ERCP. Or E, observation. So you should be thinking about D, ERCP, because again, this is a 43-year-old woman that has a history of gallstones, now presenting with elevated alk phos and bilirubin, with right upper quadrant pain and fevers. So this meets kind of Charcot's triad and suggests ascending cholangitis, in which case your treatment of choice to relieve the obstruction and drain the biliary tree is ERCP. Going over the incorrect choices: A HIDA scan can kind of help you identify acute cholecystitis in adjunct with right upper quadrant ultrasound, but not really needed for cases of ascending cholangitis. B, MRI. So MRCP can visualize the ducts, but you can't intervene on that, and you want to relieve the obstruction as soon as possible. C, cholecystectomy. You will pursue that at some point, but not in the acute setting, given that there's an acute infection going on. And E, observation. No, you need to treat this. Question 20. A 3-year-old boy presents with 2 days of fever and a barking cough. Stridor is heard at rest. A lateral neck x-ray shows subglottic narrowing. What is the next best treatment? A, azithromycin. B, racemic epi and corticosteroids. C, IV ceftriaxone. D, oral amoxicillin. Or E, no further treatment is necessary. Here you should be thinking B, racemic epi and corticosteroids, and that's because for croup that has stridor at rest, you need to be administering racemic epi with corticosteroids. Chest on lateral neck x-ray, you might see the steeple sign. That's kind of classic or pathognomonic for board exams for croup. Going over the incorrect answers, azithromycin, that's used for more like bacterial infections, like pertussis, which is your whooping cough, not really for croup, which is typically caused by viral infection. Typically on exams, it's para-influenza virus. C, ceftriaxone, again, used for bacterial infections. D, amoxicillin, not really indicated for viral infection. And no treatment is obviously incorrect. You need to do something. All right, everyone, that concludes part 1 of our infectious disease review. Make sure to like and subscribe if you haven't already, and stay tuned for part 2. Peace.